This conference will now be recorded.
Hello everyone, hope you are fine. Today inshallah we'll discuss the two important guidelines, green top guideline. The first one is about the reducing the risk of VTE during pregnancy and Puerperium. And the second guideline is also green top guideline. It is about the acute management of the thromboembolic disease in pregnancy and Puerperium. Okay, so let us start our session. Pulmonary embolism remains the leading direct cause of maternal death in UK. So you know about the causes of maternal death. It is the direct cause of maternal death in UK. NICE is the National Institute for Health and Care Excellence estimated that the low molecular weight heparin reduced the VTE risk in medical and surgical patients by 60% and 70% respectively. So here, the low molecular weight heparin, according to NICE guideline, can reduce the VTE risk in medical disease by 60% and in surgical disease by 70%. So this is the importance of the Thrombophlexis in the pregnancy and the Puerperium, because this is the high success rate of the low molecular heparin to reduce the incidence of VTE. In UK, incidence of antenatal pulmonary embolism calculated in the UK OSIS, UK Obstetric Surveillance System study is about 1.3 per 10,000 maternities. So this is about the incidence of pulmonary embolism in UK. It's about 1.3 per 10,000 maternities. This is a very important figure. So also here, the VTE incidence is about 1 to 2% per 1,000. So if you ask about the incidence of BE, you should mention 1.3 per 10,000. And the incidence of VTE is 1 to 2 per 1,000. This is the difference between the incidence of BE and incidence of VTE in the UK. And although the relative risk of VTE in pregnancy is increased 4 to 6-fold and is increased further postpartum. So antenatally, the relative risk. What does mean by relative risk? The relative risk is that means the probability of outcome in exposure group to the outcome of the unexposure group. So this is the difference between. So this is the relative risk. So relative risk of VTE is antenatal is about 4 to 6 and definitely increase further in postpartum period. So this is the about important figure in VTE and BE. Absolute incidence of VTE in pregnancy and Puerperium is 107 per 100,000 person years in UK, and the absolute risk peaked in the first 3 weeks postpartum, 22-fold increase risk. So the risk here is high immediately after delivery in early postpartum.
Excuse me, doctor. What do you mean by this absolute risk? Relative risk, yes, we understand. And what do you mean by absolute risk?
Absolute risk, it is risk of probability of the chance of the event. It is the probability or the chance of the event. So this is mean by absolute. And relative risk, it is the probability of the outcome in two groups, exposure groups to the outcome in an exposure group. This is the relative risk. And the absolute risk is the probability or the chance of the event. So this is the difference between the absolute risk and the relative risk. Is it clear?
Yes, yes. Thank you very much.
Welcome, you're welcome. First, before discuss the VTE, so first we'll take idea about the hemostasis process and the coagulation process. So first we'll discuss the hemostasis. Basically, you know, hemostasis have two types. The normal hemostasis is the primary hemostasis, which occur in seconds. This is the primary hemostasis, and secondary hemostasis, which may take minutes. So both these processes called the normal hemostasis. So what is the primary hemostasis? Primary hemostasis occur in minutes, which if there's any vascular injury, the platelet bulk formation in a site of the injury. So the platelet aggregate here in the site of injury and making bulk as the site of injury to stop the bleeding. So this is about the primary hemostasis. The aggregation of the platelet is the site of the injuries, and then forming the pulp and to stop the bleeding. So this is about the primary here, platelet pulp forming. And then here in the secondary hemostasis, here the fibrin formation by the reaction of the plasma coagulation system. So here there is the role of the coagulation system to form the fibrin. So this is about the two processes of the hemostasis and the coagulation. So here in coagulation, here the thromboplastin and platelet factors activate the prothrombin activator, which stimulus by the calcium. Then prothrombin activator with the assistance of the stimulus of the calcium can transform the prothrombin to the thrombin, and prothrombin activated the fibrinogens to the fibrin by stimulation of the calcium, and finally this blood clot formation. This is about the two important processes about the hemostasis and coagulation which occur in site of injury. Is it clear? Here, this is about intrinsic and extrinsic pathway. Here, to know what happened in the coagulation pathway. This is the cascade for coagulation. We'll talk briefly about this cascade. Here, start with an intrinsic pathway which occur in non-epithelial service, which start with the factor 12, then will be activated, then finally lead to activate of factor 10. Factor 10 here in extrinsic pathway, which occur in the if there's damage exposure to tissues factors, which tissues damage lead to epithelial cell release tissues factors, and then finally to activate with the calcium to activate 10 to active 10, factor 10 to active 10, and finally to lead to activation of fibrin and cross-linked fibrin. This is about the cascade pathway for coagulation pathway. This is about the fibrinolytic pathway. This is the against the coagulation pathway. So if you have coagulation, you should have the other system to control the coagulation pathway. This is the fibrinolytic systems. So it starts with the plasminogens to make the fibrin soluble. So here, this is inhibitors, and this is the plasminogenes activator 1 and plasminogen activator 2 and plasminogen activators 3. This is the inhibitors and this is the activators lead to formation of the plasmin, and plasmin here lead to convert of the fibrin to the fibrin degradation product. So this is about fibrinolytic system. Sorry. Now we'll talk about the pathophysiology of the VTE, or was the Virchow triad. You know Virchow triad. Basically, Virchow triad is composed of the 3 important factors. Is the development of venous thrombosis. The first is about the stasis, venous stasis. What does it mean by venous stasis? Venous stasis can occur as a result of anything that is slow or obstructs the flow of the venous blood. So if there is anything lead to the slow or the obstruct the flow of the venous blood, can lead to increased viscosity and formation of the microthrombi. So this is one of the theory of the venous thrombosis. So as the stasis. And the second one is the hypercoagulability. What does mean by hypercoagulability? This is can occur in the due to this biochemical imbalance. There's biochemical imbalance between circulating factors. There's any problem between the circulatory factors may lead to increase in the tissues activation factor, which decrease in circulatory plasma, antithrombin or fibrinolysis. And the last one is the vascular wall injuries. This is if there's any endothelial damage, may be intrinsic or secondary to external trauma. So this is about the Virchow triad, stasis and hypercoagulability, and the vascular wall injury. This is about the risk factor for thrombosis. Now we'll discuss about the pre-pregnancy and antenatal risk assessment. This is very important, this guideline. So all women should undergo a documented assessment of risk factor for VTE in early pregnancy or pre-pregnancy. So all the women should have document assessment for the risk factor of VTE early pregnancy or pre-pregnancy. This is very important. A risk assessment should be repeated if the woman is admitted to the hospital for any reason or develop other intercurrent problem. So when we can reassess the patient, repeat the assessment here if the patient admitted to hospital for any reasons and or have developed intercurrent problem. So this is about the why we repeat the risk assessment. The risk assessment should be repeated again intrapartum or immediately postpartum, because immediately postpartum there is high risk of VTE. And any woman with 4 or more current risk factor other than the previous VTE or thrombophilia should be considered for prophylactic low molecular weight heparin throughout the antenatal period, and will usually require prophylactic low molecular weight heparin for 6 weeks postnatally, but a postnatal risk assessment should be made. So by summary, we said this is all women should be documented assessment for risk factor of VTE in pre-pregnancy, early pregnancy, at admission to the hospital, intrapartum, and immediately postpartum. This is about when we'll do the risk assessment. Here, this table shows the risk factor for VTE. Here, previous VTE, except score here is very important because the time of start thrombophlexis and the dose of thrombophlexis, it depends on the score of the VTE. It is more than 4, or it is 4 score 4, or score 3, or score 2, or score 1. So here you should know about the general idea about the scores of VTE. So if there is previous VTE, except a single event related to the major surgery. So if there is VTE and not related to the major surgery, this should give a score 4. Score 4 here is antenatal is very important because you know how to manage the score 4. Antenatal. How to manage score 4.
From now on 6 weeks postnatal.
Okay, excellent, Victoria. Yeah. Yes. Score 4 is to give prophylactic low molecular weight heparin at least 6 weeks post low molecular weight heparin. So we'll start immediately by prophylactic low molecular weight heparin and at least 6 weeks postnatal low molecular weight heparin. Okay. Thank you, Dr. Narius. And previous VTE provoked by major surgery, here is the score 3. Score 3 is the management thrombophlexis from
28 weeks.
Yes,
until 6 weeks postpartum.
Excellent. From 28 weeks and at least 6 weeks postnatal low molecular weight heparin. This is the important of the score. So here, and non-high risk thrombophilia is the score 3, and medical disorder like cancer, heart disease, and active SLE, and inflammatory bowel disease and nephrotic syndrome. This is put under the score of the 3. And there is a score 1 like family history of unprovoked estrogen related VTE in the first degree relatives, and non-low risk thrombophilia, age more than 35, and obesity. And obesity, we have 2 types of the score 1 or score 3. You can give for obesity is about BMI is 30, the score 1. And if BMI is 40, score is more than 40 or class 3 obesity, you give the score 2. So this is the difference in BMI. About the age is score 1, and the parity here, if 3 or more. If parity 3, we give score 1. If the age more than 36, this is the score 1. If the patient have age 35 years, so this is have no score, score 0. So score will be as the age of 36 and above. And the parity is from the 3 and above. Smoker or gross varicose vein. What about the obstetric risk factors? The pre-eclampsia in the current pregnancy. So score 1, ART, IVF, antenatal only, and multiple pregnancy, score 1. And cesarean section in labor. Cesarean section in labor, it is the score 2. So this is emergency cesarean section. So emergency cesarean section can give her a score 2. Elective cesarean section is the score 1. So this is the difference between cesarean section. If in labor, this is you can give her a score 2. Elective cesarean section is a score 1. And the more important one requirement exam as tricky question, is the mid-cavity or rotational operative delivery. So the only operative delivery is the mid-cavity or rotational. So low forceps or the outlet have no scores. Only the score one for the mid-cavity or rotational operative delivery. If there's prolonged labor, postpartum hemorrhage, preterm, and stillbirth. And transient risk factors, here this is about any surgery in pregnancy, or perineum, except immediate repair of perineum. Appendectomy, postpartum sterilization, we give 3. And hyperemesis. So this is about first trimester risk factor. So any woman admitted to the hyperemesis should be considered for thrombophlexis with the low molecular weight heparin and discontinue thrombophlexis of low molecular heparin when the hyperemesis resolved. So if the patient presents with hyperemesis gravidarum, so you should consider for the prophylaxis of molecular weight heparin. And you can discontinue after the hyperemesis resolved. And if the patient have the ovarian hyperstimulation syndrome in the first trimesters, this can give a score 4. Score 4. So should be considered for prophylaxis in the first trimester. And the current systemic infection and immediate immobility and dehydration. Also, if there is IVF with 3 risk factor, you can give her thrombophlexis. If woman with IVF pregnancy and 3 risk factor, you consider thrombophlexis or miraculous in the first trimester. So we have 3 groups can give her thrombophlexis in the first trimester. So if there is hyperemesis gravidarum or there is ovarian hyperstimulation syndrome in the first trimester, and this patient have IVF pregnancy and have 3 risk factors, you should give her consider thrombophlexis in the first trimester. Is it clear?
Assalamu alaikum, doctor.
Wa alaikum assalam. Dr. Bardwin, you are welcome.
Doctor, in OHS, we have to give heparin for first trimester only, but the score is 4. OHS.
OHS, yes, in first trimester is have a score 4.
But the score is 4, no, doctor?
Yes, it's antenatally. You should score 4, you should give antenatal prophylactic low molecular weight immediately. But in the first trimester, you should give her immediately.
And we should continue it or only for till first trimester?
We'll discontinue only for the hyperemesis gravidarum if resolved. But in the ovarian hyperstimulation and IVF, we should continue.
No, she will receive Dr. Vte only in the first trimester, because hyperstimulation only, it will be first trimester, only first trimester, if she had no other risk factor. But if she had other risk factor, it will be considered.
Yes, you continue during the first trimester.
Yes, only. She asked she will continue or no. Yes, she will not continue.
Yes.
She will not.
But hyperemesis gravidarum will resolve. If it resolve, we will stop or discontinue the robotic. Okay, thank you.
But score 4, doctor. Will she continue it the postnatal period also?
No.
Here we'll discuss only about.
For all other you will continue, but ovarian hyperstimulation only limited in first trimester.
Yes, we'll discuss about the first trimester risk factors. Okay, hyperemesis and the ovarian hyperstimulation syndrome and IVF if associated with the 3 risk factors. This is called first trimester risk factor. Okay.
Okay, doctor. Thank you very much.
You're welcome.
Okay, thank you, sir.
Here we'll discuss about the risk assessment of VTE. we said before, if there's more than 4 antenatally, here we discuss about the antenatal periods. If more than 4 antenatally, what about the 4 antenatal? What was the score of the more than 4 antenatal? Anybody knows? At what time we said this is more than 4?
Vte. This previous means only history of Vte without any surgery, major surgery. And
if there's previous,
unprovoked.
yes, if there's previous Vte with, you should, if associated with by previous Vte plus antithrombin deficient, antiphospholipid, and other thrombophilia. So if there is any previous Vte associated with the antithrombin deficiency, antiphospholipid syndrome, and other thrombophilia, this is more than 4 antenatal score. So this is the high risk. This is the high risk for Vte. So it is recommended high dose, antenatally high dose of low molecular weight heparin, and at least 6 weeks postnatal low molecular weight heparin, or until switched back to oral anticoagulant therapy, because most of these cases already on the oral anticoagulant. So this is a score about more than 4 antenatal. The score for antenatal, if there is previous VTE, except for single ever related to the major surgery and associated with the antithrombin deficiency or ovarian hyperestimulation syndrome in the first trimester. So this is a score 4. We'll give antenatal prophylactic low molecular weight heparin at least 6-week postnatal low molecular weight heparin. And score 3 antenatally, if there is previous VTE provoked by major surgery, or there is non-high risk thrombophilia like prothrombin gene mutation, like compound heterogeneous, like homogeneous, homozygous factor V leadance, protein CS deficiency. This is about the factor 3. Also may be associated with the medical comorbidities like cancer, heart failure, any surgery proceeds, hyperemesis gravidarum during hospital admission. So this is the score 3. We'll start with from 28 weeks and at least 6-week postnatal low molecular weight heparin, 6 weeks. Okay, this is 2 or more. This is thrombophlexis for at least 10 days postpartum. This is for score 2, BMI more than 40, cesarean section in labor, thalassemia, and score 1 like family history of unprovoked estrogen, and if there is asymptomatic low risk thrombophilia. This is about score 1. So here, if you score more than 4, consider prophylaxis from the first trimester. Score 3, consider thrombophylaxis from 28 weeks. More than 2 or more, consider thrombophylaxis for at least 10 days. And if admitted hospital antenatal, consider thrombophylaxis. So this is about how to manage the patient with antenatal score for VTE.
Dr. Fatah, please, can you repeat more than 4?
Okay.
Thank you.
More than 4 antenatally, here if there is previous VTE associated with 3 important diseases: antithrombin deficiency, if there's antithrombin deficiency, or there is antiphospholipid syndrome, or there is other thrombophilia. So this associated with the previous VTE, so this is a score more than 4. This is the high risk patient for the VTE. So we'll start in the first trimester. We'll consider the thrombophylaxis from the first trimester and at least 6 weeks postnatal. It's different from the 4 antenatally. Here the antiphospholipid. If the antiphospholipid here, this is about more than 4, or in 4 antenatally, if previous VTE with ovarian hyperstimulation syndrome in the first trimester only. So this is the score 4. Is it clear?
This is the score for antenatally if ovarian hyperstimulation syndrome
The first
start
trimester only.
access
Yes.
from
Start
28 weeks or
28
from
weeks.
the first trimester.
If the score 4,
Yes, if the score for or diagnosed as ovarian
is the first
hyperstimulation
trimester.
syndrome
No, it's
start
called, yes, from the
first trimester or from 28
no,
weeks.
from the first trimester, from the 28 for the 3 antenatal. If there's 3 antenatal, if 3 antenatal, that means there is previous VTE provoked by major surgery, or
Thank you.
if there is high risk thrombophilia like protein C or S deficiency. Okay.
Okay, thank you, Dr. Fatih.
So Dr. Fatih, the difference between more than 4 and the 4 is to use high dose low molecular weight heparin for more than 4.
Yes,
Am
here
I right?
in more than 4, this is should be a start also in the immediately. So immediately, it's more than 4, because this is, we need high dose. You can start in the first trimester, and the main difference here in the dose of the low molecular weight heparin. More than 40 will give her high dose, and if there's only 4, score 4 will give prophylactic low molecular weight heparin. So this is the important, and the same is the start in the first trimester. But here we need high dose of low molecular weight heparin. Is it clear? The difference between more than 4 and 4 antenatal.
Thank you. Very clear.
Welcome. Here about the thrombophilia associated VTE. As you know, basically thrombophilia can have 2 types, inherited and acquired. So inherited like Puerperium mutation and the antithrombin deficiency and protein CS, protein C and protein S deficiency. And acquired is about lupus anticoagulant and the anticoagulability antibody. This is about the difference between thrombophilia. It's inherited and acquired. So we'll discuss first about the heritable thrombophilia, women with previous Vte associated antithrombin deficiency who will often be a long term on anticoagulant. So it's already patient on the anticoagulant warfarin, should be offered thrombophlexis with high dose low molecular weight heparin, either 50 to 75% of or full treatment dose antenatally and for 6 weeks postpartum until return to the oral anticoagulant therapy as after delivery. The management should be undertaken in collaboration with the hematologist expertise in thrombosis in pregnancy and consideration give to the antenatal monitoring and the potential for antithrombin replacement at initiation of labor to prior cesarean section. So this is discussed before, already discussed. Acquired thrombophilia, woman is Vte associated with the antiphospholipid. Antiphospholipid should be offered thrombophlexis with high dose low molecular weight heparin as heritable. Also high dose of low molecular weight heparin is either 50 or 75% or full treatment dose antenatally and for 6 weeks postpartum or anti-return to the oral anticoagulant therapy after delivery. Pregnant woman with antiphospholipid syndrome and prior VTE or arterial thrombosis should be managed in collaboration with hematologist and or rheumatologist with expertise in this area. What about the previous VTE? Advice regarding dose of low-molecular heparin in pregnancy should be sought from clinician with expertise in hemostasis and pregnancy. This is recommendation. Women on long-term warfarin or others, or with oral or other oral anticoagulant should be counseling about the risk of this agent to the fetus, and advised to stop their oral anticoagulant therapy and change to low molecular heparin as soon as pregnancy is confirmed, ideally with 2 weeks of the missed period and before 6 weeks of pregnancy. So this is about warfarin and pregnancy. What is the problem of warfarin with pregnancy? What is the problem? What is the congenital abnormality?
Teratogenesis
Warfarin embryopathy.
Warfarin embryopathy.
It's cartilage, skeletal, hydrocephalus.
Characteristic of the warfarin. Warfarin syndrome. What, Dr. Narius? Yes, this is the warfarin embryopathy. It is about 5%, and it is occur between 6 to 12 weeks. So this is so important. Should be ideally within 2 weeks of the missed period. Should stop the warfarin within 2 weeks of this period, and before 6 weeks, sorry, of pregnancy, because the between 6 to 12 weeks, this is the period of the warfarin embryopathy, which is about 5% and characterized by the hypoplasia of nasal breach and agenesis of the corpus callosum and the sudden nose and retarded growth and defect of the limb. This is about maybe came in exam asking about the warfarin or the fetal warfarin syndrome. Women not on warfarin or other oral coagulation should be advised to start heparin as soon as they have a positive pregnant test. Women with VTE associated with either antithrombin deficiency or antiphospholipid syndrome, or with recurrent VTE, should be offered thrombophlexis with high dose low molecular heparin antenatally and for 6 weeks postpartum, or until return to the oral anticoagulant therapy after delivery. Women in whom the original VTE was unprovoked, idiopathic, or related to the estrogen, or related to the transient risk factor others than major surgery, or who have other risk factors, should be offered thrombophlexis with low molecular heparin throughout the antenatal period. In women in whom the original VTE was provoked by major surgery, this is the score 3, from which they have recovered and who have no risk factors, thrombophlexis with low molecular heparin can be held antenatally until 28 weeks, provided no additional risk factor are present, in which they should be offered low molecular heparin. How to testing for thrombophilia? Prior to testing for thrombophilia, women should be counseled regarding the implication for themselves and family members of a positive or negative result. The result should be interpreted by clinician with specific expertise in this area. So, women with a family history of VTE and either antithrombin deficiency or where the specific thrombophilia has not been detected should be tested for antithrombin deficiency. woman is unprovoked VTE should be tested for the presence of antiphospholipid antibodies. So phospholipid antibodies with the previous VTE will score more than 4. So the screening for the antiphospholipid antibodies is very important. Asymptomatic heritable thrombophilia is protein C and protein S, and those with the more than one thrombophilic defect should be referred to a local expert and antenatal prophylaxis considered. So this is the non-high risk of thrombophilia. So this is high risk of thrombophilia, and this is the score 3. They should be recommended for 6 weeks postnatal prophylaxis, even in the absence of additional risk factors. Heterozygosity for Vector V lesions or prothrombin gene mutation or antiphospholipid antibodies are considered as the risk factor for thrombosis in asymptomatic women. So this is if the patient asymptomatic, we should look for the heterozygosity for factor V lesions and the prothrombin gene mutation antiphospholipid. Women with no personal history or risk factor for VTE, but who have the family history of unprovoked or estrogen-provoked VTE in the first degree relative when age under 50 years should be considered for thrombophilia testing. This is about at what time you test for thrombophilia. And asymptomatic heritable thrombophilia, women with asymptomatic antithrombin, protein C, or protein S deficiency, or those with more than one thrombophilic defect should be over to the local expert and antenatal prophylaxis considered. They should be recommended for 6 weeks postnatal prophylaxis, even in the absence of additional risk factors. Here, this is table summary of the previous table about the more than 4. It is very high risk is 4, score 4, and intermediate risk score 3, and low risk. So here is very high risk. This is the previous VT or long-term oral anticoagulant therapy. And if this associated with the antithrombin deficiency or antiphospholipid with the previous VTE. So this is the very high risk. So we recommended antenatal dose lomorecotiferin at least 6 weeks postnatal lomorecotiferin or antirestrictive back to the oral anticoagulant therapy. And high risk if there's any previous VTE not related to the major surgery is a recommended antenatal and 6 weeks postnatal. Intermediate also here from the 28 weeks of gestation and 6 weeks, and low risk is about 10 days postpartum. This is summary of the previous table, and this is about antiphospholipid antibodies. Antiphospholipid antibodies, persistent antiphospholipid antibodies, lupus anticoagulant, or anticardiolipin and or B2 glycoprotein 1 antibodies in women who without previous VTE should be considered as the risk factor for thrombosis, such that if she has the other risk factor, she may be considered for antenatal or postnatal thrombophlexis as above. Here, this is very important table about the obstetric thrombophlexis risk assessment and factor. So this is also a summary about all the table discussed before. So we'll divide the patient is high risk and intermediate risk and the low risk. So high risk, this is require antenatal prophylaxis with low molecular weight heparin. So this is the score 3 and score 4. Score 4 and more than 4. So this is the high risk. If there is any previous VTE, except related to the major surgery. If related to the major surgery, this is the score 3. So any previous VTE, except related to the major surgery, this is the high risk patient. So require antenatal prophylaxis low molecular weight heparin. And intermediate risk, so consider antenatal prophylaxis low molecular weight heparin if there's any hospital admission, single VTE related to the major surgery, high risk thrombophilia like protein S and C deficiency and homozygous vector V lesions, and this is about compound heterogeneous heterozygous. So this is the high risk VTE, and no VTE, no history of VTE, this is intermediate risk, and medical comorbidities like cancer, heart failure, and nephrotic syndrome. Any surgery precedes appendectomy and ovarian hypertension syndrome in the first trimester. And if there is 4 or more risk factor, prophylaxis from the first trimester, 3 risk factor, prophylaxis from 28 weeks. This depends on these factors. Obesity, age more than 35, poverty 3 and more, smokers, cross varicose vein, current preeclampsia, immobility, family history, low risk thrombophilia, and this IVF and multiple pregnancy. So this is if fewer than 2, fewer than 3, 2 risk or below, this is the lower risk, and for the mobilization and avoidance of dehydration. This is the antenatal. And postnatal assessment, here the high risk at least 6 weeks. So the patient high risk, you should at least 6 weeks postnatal prophylactic low molecular weight heparin. In any previous VTE, any one require antenatal low molecular weight heparin. So if there's any patient on antenatal low molecular weight heparin, high risk thrombophilia and low risk thrombophilia, and there is family history of thrombophilia. And intermediate risk at least 10 days.
What are high risk and what are low risk thrombophilia?
What about the low risk thrombophilia? If there is low risk thrombophilia and associated with the family history of thrombophilia, and
So
only
what are the
high
examples?
risk, it can be considered as the high risk thrombophilia. But low risk, if accompanied with the family history, so will consider as the high risk. If there is intermediate, cesarean section labor, BMI 40, class 3, obesity, readmission, any surgical procedures, and medical comorbidities. And 2 risk factors from anyone of the age, obesity, more than 3, poverty, smoker, elective cesarean section, score 1, family history of VTE, low risk thrombophilia, and cross varicose vein, current systemic infection, immobility, and current preeclampsia, multiple pregnancy, preterm this pregnancy, stillbirth in this pregnancy, and mid-cavity rotational operative delivery. There's many questions came in asking about this, and prolonged labor and postpartum human. This is if there's 2 or more, so we'll as intermediate risk, and we'll give her if the 3 score, we'll start about the consider standing thrombophlexis with low molecular weight heparin. If fewer than 2 risk factor, we'll manage as the low risk and early mobilization and avoidance of dehydration. This is about antenatal assessment management and the postnatal assessment management of the VTE.
Doctor, can you just give example of high risk thrombophilia and low risk thrombophilia? Example.
Here, yes, high risk thrombophilia for the protein C, and protein S deficiency. If they give you a scenario about the patient with the protein S and protein C deficiency, this is the high risk thrombophilia. Or said this is homozygous factor V lesions. It is the homozygous. This is also can consider as the high risk thrombophilia.
And low risk thrombophilia. Example.
For example,
heterozygous factor V laden mutation.
Low risk. It is said
on prothrombin gene mutation also.
Yes. Homozygous heterozygous prothrombin or heterozygous factor V leaders or sickle cell triad. This is about the low risk thrombophilia. If said there is homozygous, so this is should be high risk. If there is heterozygous, single heterozygous, this is the low, or compound heterozygous, this is the high risk. Okay?
Okay.
You know the
okay,
difference
thank you,
between...
doctor.
You are welcome.
Sir, and antithrombin 3 is also high risk, no?
Heterozygous, yeah?
Heterozygous, it will be high risk if compound. If single heterozygous, so this is for the low. If you said this is...
Sir, antithrombin 3 deficiency, that is also high risk only, no, sir? Antithrombin 3 deficiency.
Antithrombin 3 deficiency, high risk. Homozygous,
yes.
Intermediate risk. Heterozygous, this low risk.
Prothrombin gene mutation is low risk.
It is low risk.
Yes, low risk.
Thank you. Thank you.
Thanks.
You're welcome. This is the summary of the schedule. So, what about the thrombophlexis during labor and delivery, including the use of regional analgesia? So, women receiving antenatal low molecular heparin should be advised. What Dr. Marius? Who's confused? The heterozygous or the homozygous? Dr. Marius?
Yes, Dr. Fateh.
Yes. Okay, we'll be clear. Here, if there's high risk thrombophilia, if said there's homozygous, this is the high risk. The exception here in the heterozygous. Heterozygous will be low risk thrombophilia if single. If said heterozygous prothrombin. If said there's compound heterozygous, so this is the high risk thrombophilia. So this is the only difference in the heterozygous. If there's heterozygous prothrombin, this is the low. If there's compound heterozygous, this is the high risk. And the homozygous, this is the high risk. Okay, is it clear? Okay. Regional technique.
Okay, thank you. Clear now. Thank you.
You are welcome. Regional technique should be avoid. Women receiving antenatal low molecular heparin should be advised if have any vaginal bleeding or once labor begin, they should be not inject any further low molecular heparin. So, thank you, Dr. Marius. So, if the patient already on low molecular heparin and develop any vaginal bleeding or the patient become in labor, should stop the low molecular heparin. Regional technique should be avoided if possible until at least 12 hours after the previous prophylactic dose of low molecular heparin. We have, inshallah, we'll have table, we'll discuss this later. A low molecular heparin should not be given 4 hours after the use of spinal anesthesia or after the epidural and catheter have been removed, and the catheter should not be removed within 12 hours of the more recent injection. So you should avoid regional analgesia at least 12 hours after the previous prophylactic dose, and how many will stop or to avoid the regional technique after the therapeutic dose? How many?
24 hours. 24 hours.
Yes, excellent. Thank you. Yes, should be avoid the regional technique after 12 hours from the prophylactic dose of lumefantrine and 24 hours from the therapeutic dose of the lumefantrine. This is very important. A lumefantrine should be not given after use of regional spinal anesthesia or after epidural catheter have been removed, and the catheter should be not removed within 12 hours. So if you give low molecular heparin, if you give spinal, avoid low molecular heparin before 4 hours. And if you have the catheter, it should be removed after 12 hours of the most recent injection. So after 12 hours from the injection of the low molecular heparin, you should remove the catheter or you do spinal anesthesia. Is it clear?
Please repeat the point of 24 hours.
Yes, here 24 hours. Here, if regional technique will avoid the regional technique if you give the patient injection before 12 hours. So at least 12 hours after the prophylactic injection of lumefantrine, you can do regional technique. In case of patient have prophylactic dose, if you can, if they give the patient at 6 p.m., 6 a.m., 6 a.m. prophylactic dose of the lumefantrine, you should avoid 12 hours regional analgesia. So you can give her the regional analgesia after 12 hours. It is at 6 p.m. at least from the prophylactic dose. If this is thrombotic dose, we'll avoid 24 hours. So this is the difference between the prophylactic dose of lumefantrine and therapeutic dose of low molecular heparin. And if you give the patient spinal anesthesia, you should give the low molecular heparin after 4 hours. So don't give the patient have received spinal anesthesia with low molecular heparin within 4 hours. So we give her after the 4 hours. And if you give the low molecular heparin, you should avoid to remove the catheter within the 12 hours of the recent of the injection. If you give the injection, you will remove the catheter after 12 hours. So we have an algorithm, inshallah, we'll discuss it again.
These questions, Dr. Fat, are always coming in the exam about these 4 hours, 12, always at least 2 questions coming in the exam.
This is tricky area, really, this is tricky area. I will
honestly, it's tricky. Honestly, it is tricky.
Okay, Dr. So we'll discuss it. Okay. No
it
problem.
It is tricky, really.
Yes, we'll discuss it.
Okay, thank you.
No problem.
Dr. Fatih, about low molecular
Vte
heparin, yeah, there is any antidote for it? Because there is one question before in the exam, patient she received low molecular Vte heparin and she came with postpartum hemorrhage. What we will give? She had any antidote for low molecular Vte heparin?
Low molecular Vte heparin?
Yeah.
Really, I'm not sure. Right.
Protamine is the antidote for.
Sorry, what was the question?
No. The question, the patient she received low molecular Vte heparin and she came with postpartum hemorrhage. The question about to give the patient fresh frozen plasma or to give this protamine sulfate.
Protamine sulfate.
The low
protamine sulfate for unfractionated heparin. For unfractured. Yes,
exactly.
Yeah.
Yes.
Okay.
This was a summary about the previous slide, and yes, okay, thank you, Dr. Moss. It is about protamine sulfate. Okay, here this is about summary of the at what time we stop or give the lumecric heparin. Here, if there's prophylactic dose, we said after 12 hours, you can give her regional analgesia. Agree? Or induction of labor. So cesarean section, the original technique. And if therapeutic lumecric heparin should be avoided 24 hours. Induction of induction or the regional technique. So this is about the lumecric heparin. And if you do regional technique, you should at least 4 hours to give the prophylactic dose of lumecric heparin. So this is briefly about the previous slide. Is it clear? This if there's prophylactic.
Yes, very clear now, doctor. It's very clear now. Yeah. Thank you.
This is about women receiving antenatal lumecric heparin. Cesarean section should be receive a thrombophylactic dose of lumecric heparin on the day prior to delivery and the day of the delivery. Any morning dose should be omitted and the operation performed that morning. Let's repeat it. Yes. Okay. Which agent should be used for thrombophlexis? Lumecric heparin. Low molecular weight heparin. Low molecular heparin are the agent of choice for antenatal and postnatal thrombophlexis. And the dose of low molecular heparin are based on the weight. For thrombophlexis, the booking or most recent weight can be used to guide doses. So we'll use the most recent weight. It is the only necessary to monitor in the platelet count if the woman has prior exposure to unfractionated heparin. Monitoring of the level is not required when low molecular heparin is used for thrombophlexis. Dose of low molecular heparin should be reduced in women with the renal impairment. Low molecular heparin is safe in breastfeeding. This is about suggested dose of thrombophylactic dose for the antenatal and postnatal low molecular heparin. There's many questions came in exam asking about the dose and the dose of enoxaparin or dalteparin or tenzaparin. So it's very difficult to remember, to memorize that, but I will try to make it as symbols. So this is, yes, Dr. Hasniya, this is very important. Here we'll start with the weight. If you memorize less than 50 kilograms, if you can memorize a weight more than 50, and in each weight you can add it more than 40 here. If you added 40 for 50, will become 50 to the 90 kilogram. If added 40, will be 130, and will be 140. So 50 first will add 40 to memorize all this chart. So first will weight, and the most weight came in exam asking about the dose here, about the between 91 and 130 kilograms. This is very important dose because a lot of question came in exam asking about this exactly. And if you added 40 for the 50, will be 90, will be 130 and 140. So what about enoxaparin or dalteparin or the tenzaparin? So the dose of enoxaparin start first with 20 milligrams daily. If there's 50, so we'll add it 20 here, we'll add it 40. Here we'll add it 40, 20 will be 40 in case of 50 to 90. And if this kilogram is 91 to 130 kilograms, we'll add it 20 it will be 660, and we'll add 20 in weight of 170 will be 80 milligram daily. So here enoxaparin will start with 20 and we'll add it 20. So if the weight 50 to 90 will be 40, if the 91 to 31 will be 60, and 131, 170, the enoxaparin dose will be 80 milligram daily. This is about enoxaparin. Deltaparin, here also the dose is different. We'll add it also 40. Here for 50 kilograms, less than 50 kilograms, we'll give her 2,500 unit daily. We'll start dose with 250, 500 unit daily. If the weight is between 50 to 90, we'll add it about 2,500. So this is will be doubles here. This is 5,000. And here in weight of about up to 130 will be 7,500. So we'll increase 2,500 for the deltaparin. And for enoxaparin, we'll add it 20. And tenzaparin, here, the dose will start with 3,500 and will be double with the 91 to 130. And after that, 4,500 with 50 to 90 kilograms, and will be double with the, will be 9,000 with 131 to 170. This is briefly about the dose of enoxaparin and deltaparin and tenzaparin. If give you scenario more than 170 kilogram weight, so 0.06 milligram per kilogram per day. This is for enoxaparin, and 75 units per kilogram per day for deltaparin, and 75 the same as deltaparin. This is the dose of the tenzaparin. And if there's high dose for waiting for the 50 to 9 kilograms, there will be 40 milligram 12 hourly, here 5,000 12 hourly, here 4,500 unit 12 hourly. Here important here is to remember here to add it 40 for the weight, and to add enoxaparin will add it plus 20, and deltaparin will plus 2,500, and the tenzaparin will double here and become double in up to 130, and 4,500 will be double here in about up to 170. This is about how to memorize the dose of because very difficult. Really, it's very tough and very difficult to remember this. Is it clear?
Yes, thank you.
Okay.
Yes, it's clear. Thank you.
You're welcome. Other type of thrombophlexis is this unfractionated heparin, known at very high risk of thrombosis. Unfractionated heparin may be used prepartum in preference or to low molecular heparin, where there is increased risk of hemorrhage or where regional anesthetic technique may be required. So this is at what time we say we'll use the unfractionated heparin. If unfractionated heparin is used after cesarean section, the platelet count should be monitored every 2 to 3 days from day 4 to 14 or until heparin is stopped. This is important because maybe SPA question. If you have unfractionated heparin, we need to monitor the platelet count at the day 2 to 3. Every 2 to 3 days from day 4 of the operation until the day 14, or until the heparin is stopped. So we'll need platelet count monitoring. Then opioids, this is potential use should be, this is potential use of tanaproid should be in conjunction with the consultant hematologist with expertise in hemostasis and pregnancy. So this is, it is mostly used in patient interrelated of heparin, either be case of the HIT or skin allergy to heparin. Fondaparinux, this is should be reserved for women interrelated of heparin compound, and the fondaparinux is used in pregnancy should be in conjunction with a consultant hematologist with expertise in hemostasis and pregnancy. Low dose aspirin is not recommended. Warfarin used in pregnancy is restricted to the few situations where heparin is considered unsuitable. Example, some women with the mechanical heart valve. So this is the question SPA asking about will we use the warfarin or the stop the warfarin. So warfarin, the pregnancy is restricted for the some women with mechanical heart valve. So this is very important to continue warfarin. Women receiving long-term anticoagulant with warfarin can be converted from the low molecular weight heparin to warfarin postpartum. Yes, Dr. Hasni, risk benefit. I would get the benefit of the risk. When the risk of the hemorrhage is reduced, usually 5-7 days after delivery. Warfarin is safe in breastfeed. This is about anti-embolism stocking. The use of properly applied anti-embolism stocking of upper breast size and providing graduated patient with calf pressure of 40 to 50 millimeter mercury is recommended in pregnancy, and the Puerperium for the women are hospitalized and have the contraindication for low molecular heparin. So if these patients have in contraindication for low molecular heparin and admitted hospital, you should use the anti-embolism stocking for the calf pressure is 14 to 15 millimeter mercury. This includes women are hospitalized post cesarean section combined with the low molecular heparin and considered to be particularly high risk of VTE, and women traveling long distance for more than 4 hours. So this is also question or if the woman of more than 4 hours, this is the indication for anti-embolism stocking. This is about contraindication and caution use of the low molecular heparin. If there is no bleeding disorder, example for hemophilia, Von-Willebrand disease, or acute coagulability, active antenatal or postpartum bleeding. So this is maybe using caution, the benefit outweighs the risk. Women consider increased risk of the major, hemorrhage in the placenta previa, thrombocytopenia, and acute stroke previous 4 weeks, severe renal disease, severe liver disease, and uncontrolled hypertension. This is about the contraindication and the caution to use the low molecular weight heparin. This is all about the reduced risk of VTE in pregnancy and Puerperium. So we'll discuss the next guideline, thromboembolic disease in pregnancy and Puerperium is acute minimum. This is the simple guideline. Venous VTE, venous thromboembolism, remain the one of the main direct cause of maternal death in the UK. The prevalence of Ultimately, diagnosed PE in pregnant women with suspected PE is 2 to 6%. The majority of women with VTE in pregnancy have clinical symptoms. This is either DVT or BE. What is the difference between DVT and PE? Because many questions came in exam and give you a scenario about the symptom of DVT and symptom of VTE. Here is a leg pain and swelling, important symptoms, and usually unilateral, and lower abdominal pain, extension of the due to extension of the thrombus into pelvic vessels and or develop of collateral circulation. So this is the important symptoms: leg pain and swelling and lower abdominal pain. And BE can be symptomatic as dyspnea, chest pain, and hemostasis and collapse. So this is the important keywords for the BE, as this patient presents with chest heaviness or chest tightness, dyspnea, chest pain, hemostasis, and collapse. This is may give keyword for the BE. Low-grade pyrexia and leukocytosis occur with the VTE. This is table shows the difference between the differential diagnosis of maternal collapse here in case of pulmonary embolism, amniotic fluid embolism, in eclampsia and hemorrhage. So if the patient is PE, the important clinical feature here is the massive pulmonary embolism, so leading to collapse associated with the central chest pain. This is very important keyword in scenario. Onset is usually sudden and associated with the breathlessness and may be associated with the hemostasis and sinus tachycardia, or there's GVB and sinus of the right heart strain. This is about the examination and investigation. The risk is high in obese, older woman, post-cesarean section of surgery, and those with the previous thromboembolism or thrombophilia. So how to investigate it? So the important is the chest X-ray. In BE is very important. We'll discuss later. ECG change is very important. ABG, arterial blood gases, and ventilation perforation lung scan, SATABA, and the pulmonary angiography or the echocardiogram. Amniotic fluid embolism, which occur mainly during labor or during and immediately following the precipitous labor with the intact membrane, the intact amniotic sac. So predisposing factor is increasing age, hypertonic uterine contraction, uterine stimulants, uterine trauma, and induced labor. So this is about, and investigation here is the chest X-ray. It's very important. Eclampsia or the seizure is the characteristic by tonic colonic seizure. So this occurs mostly as postpartum periods, and the hemorrhage also here maybe lead to collapse. And pneumonia also, pneumothorax, and acute coronary syndrome and aortic dissection. This is about the causes of differential diagnosis of the collapse. So how to diagnose VTE? Any woman with the symptom and or signs suggestive of VTE should be objective testing and treatment with low molecular heparin given until the diagnosis excluded by the objective testing unless the treatment is strongly contraindicated. So if the DVT remain untreated, so why we treat the DVT immediately? Because if untreated, is about 15 to 24% of this patient will develop BE. So this is very important because if you delay in the management and DVT, So, or untreated, so the patient untreated, so will develop Vte in about 15 to 24% of the patient. BE during pregnancy may be fatal in almost 15% of patients, and 60% of this death will occur within 30 minutes of the embolic event. So this is why important should be manage the DVT to reduce the risk of BE. So if you reduce the risk of BE, so will decrease the death from the BE. So this is so DVT, the blood should be taken for the full blood count, coagulation screen, urea and electrolytes, and liver function test. So this is about the DVT. Patient complex ultrasound should be undertaken where there is clinical suspicion of DVT. So if there is any clinical suspicion, if there is leg pain and swelling, and there is lower abdominal pain, or there is any symptoms suggest DVT, you should do blood investigation. So first, we suspect DVT, we'll do clinical assessment, then we'll test for full blood count, urea and electrolyte, liver function test. And after that, you should commence low molecular weight heparin. Don't wait for the result of the investigation. So the other after will start or commence the low molecular weight heparin, then we'll do the compression complex ultrasound. If the ultrasound is negative and there is low level of clinical suspicion, anticoagulant treatment should be discontinued. So we'll look for the result of the ultrasound. If negative, and you should look for the suspicion. If there is low suspicion, you should discontinue the anticoagulant. If there is high suspicion, anticoagulant treatment can be discontinued, but the ultrasound should be repeated the day 2 and day 7. Here, this is very important. You should look for the ultrasound is negative or positive. If it's negative, look for the suspicion, clinical suspicion. If the low, you should stop the anticoagulant treatment and no need for the follow-up by ultrasound. If there is high level and the ultrasound is negative, you should discontinue the low molecular weight heparin and you'll do ultrasound as the day 3 and day 7. If after day 3 and day 7 the testing become negative, so there is no further treatment is required. If repeated and confirmed there is presence of DVT, so we'll recommend to continue the treatment. So this is if the ultrasound is negative, you have two options: if low clinical suspicion or high level of clinical suspicion. If low level of clinical suspicion, you should discontinue low molecular weight heparin. If high, you should do ultrasound at day 3 and day 7 and discontinue treatment. If negative, will stop the treatment, and if positive, will continue the treatment. Is it clear?
Yes, doctor, it is very clear.
Yes. Women presenting with symptom and sign of acute BE, pulmonary embolism.
Yes, doctor, thank you. It's clear. It's very challenging, but we are trying to absorb that whole information very nicely. You are guiding us. Thank you, doctor.
Thank you, Dr. Sima. You are welcome. Really. Okay. Women presenting with symptom and sign of acute pulmonary embolism should have ECG and chest X-ray, because here many question exam recall question ask about the ECG change and if the chest X-ray is normal or the abnormal. Okay, ECG can be abnormal in 41% of women with acute BE. So the most important change here is the T wave inversion. In exam will give you T wave Vte or the T wave and set S1 Q3 T3 parents as the bride bundle branch. So this is the most important case here. T wave inversion is about 10%, and right pendle branch block in 18%. So this is the most important change. Also, there's S1 and Q3 and T3 parents about 15%. So chest X-ray may be indefinitely other pulmonary, identifies the other pulmonary disease such as pneumonia, pneumothorax, or collapse. Here, this is about investigation and initial management of suspected DVT in pregnancy and pregnancy. So first, if you suspect DVT, there's some signs or symptom like abdominal pain, lower abdominal pain, or there's hemostasis, or there's there's lower abdominal pain or leg pain and swelling. This is suspect DVT. So we'll do clinical assessment. So we'll examine. Yes, it's S1 and Q3. This is the February recall. And we'll do clinical assessment. After that, if there's already suspected, we will test, take blood sample for full blood count and urea and electrolyte and liver function test. This is very important steps before to starting or to commence low molecular weight heparin, because EMQ, the exam came in this like this way. Okay, first we'll start with the clinical assessment. After that, we'll choose the blood sample for the full blood count, urea, electrolyte, and liver function. After that, we commence low molecular weight heparin. So then perform compression duplex ultrasound. This is the steps of the how to deal with the patient of DVT. If the present ultrasound confirmed DVT is yes, so we'll continue the dose of lumefantrine. The problem here is negative. If negative, we look for the level of the clinical suspicion. If low and negative, we'll discontinue treatment. If the low and there's high suspicion of the clinical suspicion, so we'll here in the day 4 and 7, and if there's negative, we'll discontinue, and if the positive, we'll continue treatment. Okay, here day 3, sorry, day 3 and day 4. This is about high clinical suspicion. If negative, we'll discontinue treatment. If the positive, we'll continue the treatment. Okay. Here, this is about the diagnosis of PE in the pulmonary hypertension in pregnancy. Here also, if you suspect PE, so we'll look for the start first with the investigation, ABG, ECG, and chest X-ray, and start anticoagulant low molecular weight heparin dose. So here, assessment is very important. Is the patient stable or unstable, or it is clinically urgent? Here, if the patient is stable, you can do ultrasound. You can do double ultrasound. If positive, we'll continue the anticoagulant. And if there is negative, we look for the chest X-ray. If chest X-ray is normal, we'll do VQ scans. If positive, we continue, or is negative, we'll do fataba. Okay, and if if the negative, we'll stop the anticoagulant. If positive, we'll start IV heparin. If the patient is the clinical urgent, if this is massive. If the patient is unstable, we need to do portable echocardiogram. So this is urgent when if there's any massive, if you have any massive pulmonary embolism, it is you can do portable echogram. What is the characteristic of the acute PE or the massive pulmonary embolism? If they have one of these criteria. If the systolic blood pressure less than 90 millimeter mercury for more than or for 15 or more than 50 minutes, or if there is persistent profound bradycardia, heart rate less than 40 beats per minute with symptom or sign of shock, or there is pulseless. So this is the three. This is about the massive pulmonary embolism. We need, this is the indication for portable echocardiogram. So we'll do portable echocardiogram or the SOTAB with 1 hour of the presentation. You should do this with 1 hour if the patient unstable, within 1 hour of this presentation. So finally, we'll give the patient IV heparin because this is the massive pulmonary embolism. So this is about how to manage pulmonary embolism and massive pulmonary embolism. Is it clear?
Repeat that point of massive pulmonary embolism. 3 features, doctor.
Pulmonary passive
Systolic blood pressure more less than 90.
Yes, we have 3 criteria for to do the portable echocardiograms. This is means the presentation of the massive thromboembolism because it is massive life-threatening. Here will if the systolic blood pressure less than 90. Yeah, if the systolic blood pressure less than 90 and millimeter mercury for the 15 or more minutes. This is very important. Okay. The second criteria is the persistent profound bradycardia. Is the HR heart rate is less than 40 beats per minute with symptom of sign of shock, or there is pulselessness. This is about the 3 important things. This is the indication for portable echocardiogram. You should, this is suggest of the massive Vte. So you should do the portable echocardiogram or the SATABA within 1 hour of this presentation. Because the massive life-threatening Vte need multidisciplinary team, we give her unfractionated, and SATABA and the portable echocardiogram should be done with 1 hour of the presentation. So the dose here is about 8 units per kilogram, followed by about 18 units per kilogram per hour. So, and we need to measure ABBT 4 to 6 hours after loading dose and 6 hours after any dose change day when it's therapeutic. This is previously about the massive life-threatening Vte. So the most important, we need multidisciplinary team. We'll give her unfractionated heparin and the indication for SATABA and portable echo in 1 hour if they have systolic pressure less than 90 or the persistent profound bradycardia less than 40 heart rate, or there's pulseless, there's no pulse. So this is 3 important indication for portable, and SATABA should be done 1 hour, and we give the IV heparin is about 80 units per kilogram, followed by 18 units per kilogram per hour. This is the dose of heparin, and you need to measure ABTT 4 to 6 hours after loading dose. If you give the loading dose of heparin, you should measure after 4 to 6 hours ABTT, and then 6 hours after any dose change. If you change any dose, you should do the ABTT daily when it's therapeutic range. So this is previously about the therapeutic massive Vte. Is it clear?
Sorry,
Yes, Dr. Fateh.
I have one question.
Dr. Fateh, about this point. Hello?
Hello?
Yeah, Dr. Fateh, there is one question in September. They not mention the patient is stable or unstable, but mention the patient, she had sign and symptom of pulmonary embolism. And when they did the chest X-ray, it is showable pleural effusion. So for this reason, I will go with echo or I will do CT pulmonary. Which one I will choose? Because both is the option.
portable if the patient unstable. Yeah, the
If not
indication
mentioned in the question, stable, unstable.
you-
Only
you
they
should-
tell the chest X-ray show pleural effusion.
there is no clear guideline here to mention SATABA or portable, but you can choose SATABA because SATABA is the clinical agent. In clinical agent will do the first SATABA, but the echo portable echo according to the Royal College in only the unstable patient for the massive BE. So if you give two options, you choose SATABA. If there's in the scenario, if you feel this is patient unstable or this is any sign of massive VE, you can choose either SATABA or the portable echocardiogram. Is it clear, Rasnia?
Okay, clear.
Any
Clear,
question?
clear. Thank you, thank you.
Welcome.
Dr. Fatih, I have one question.
Yes, Dr.
If if the chest X-ray is normal, we will go to do VQ scan. If the VQ scan it is normal, I will stop the treatment or I will go for the SATABA. Here is the diaphragm. If positive, I will continue, but if negative, I will stop the treatment or I will go.
Yes, I got the point. Yes, if VQ scan is negative and if there is any still suspicion of VE, you can choose SATABA. You can do SATABA. If there is no suspicion or there is no suspicion, you can discontinue treatment. But if there is still suspicion and VQ is negative, you can do SATABA. Okay?
Okay, thank you.
Yeah, this is algorithm of the management of BE. It's the same like VTE, DVT. Also start with clinical assessment, perform blood investigation and chest X-ray and ECG, and start commensurate microtubular. If there is symptom and sign of DVT, because we said DVT, if not treated, will increase risk of BE. If there's any sign of DVT, yes, should be present duplex ultrasound. If it is positive, we'll continue treatment. If negative, here we'll do chest X-ray. We'll look for chest X-ray. Chest X-ray is normal, we'll perform VQ scan. So if it's abnormal chest X-ray, we'll perform SATABA, and this we look for if the BE is confirmed. So if positive, we continue. If negative here, it depends on the clinical suspicion. If low, discontinue the low molecular tubular. If this clinical suspicion is high, consider alternative or repeat testing or continue low molecular tubular. You have option here. If there's all the investigation is negative and difficult to confirm, and still there's suspicion, you can consider alternative or repeat the testing or continue low molecular tubular. You have here a 3 options. Okay?
Yes.
This woman was suspected BE, and symptom and sign of DVT should be bilateral patient duplex ultrasound. And here we'll repeat the algorithm. Here is repeated. Yes, okay, here. This is here about the VQ and SATABA because many questions in exam cap and about the chest X-ray and the risk of the VQ and risk of SATABA on the fetus. Okay, here the SATABA more readily available. There is lower radiation to the fetus, but it's associated with the increased risk of breast cancer. This is very important. Here, the SATABA
Which one, doctor? Can you repeat?
Okay.
Which one is with the breast cancer, doctor? CTPA?
Okay. Yes, CTPA. Increase the risk
Yes,
of
yes.
breast cancer.
Mm-hmm.
So this is more ready available, and there is lower radiation to the fetus. So VQ have high radiation with the fetus, so associated with increased childhood cancer. But طبعا here is CT,
yes,
the increased risk of breast cancer.
I remember this was a question, I think, in February exam, February 2020. It's been one question about this.
Yes, yes, you're right about the VQ and yes.
That's right.
Yeah,
CTPA,
February 10. Thank you, Dr. Hasni. VQ scan may
You're welcome,
carry
doctor.
slightly increased risk of childhood cancer, but it's associated with the lower risk of maternal breast cancer in both situations, and absolutely risk is very small. So it is about our CTPA is this it's associated with the risk of breast cancer, and the VQ is with childhood cancer. Here, this is table show the advantage of CTPA or SOTBA or VQ scan. Lower dose of radiation to the fetus, and here is lower dose radiation of the breast cancer. So this is related to the breast cancer, and this is related to the childhood cancer. What about the baseline blood investigation? The blood should be taken for full blood count, coagulation screen, urea electrolyte, and liver function test prior to anticoagulant syrup. Performing a thrombophilia screen is not recommended. The initial anticoagulant treatment, yes, thank you, Dr. Asia. In clinical suspected DVT BE, treatment with low molecular heparin should be commenced immediately until the diagnosis is excluded by objective testing, unless treatment is strongly contraindicated, because it does not cross the placenta and not associated with increased risk of postpartum hemorrhage, and reduced risk of heparin-induced thrombocytopenia, and reduced risk of stenosis. This is about the benefit of low molecular heparin. Low molecular heparin should be given in dose titrated against the woman booking or early pregnancy weight. There should be a clear local guideline for those. Here also about the initial dose of enoxaparin determined as the follow. Here is different from the thrombophlexis. Here is the therapeutic dose. Is the schedule for the enoxaparin is the same. It is the same. We'll add it 20, and here we'll add it 20. So if the patient have 50, if this patient less than 50 kilograms, the dose is about 40 milligram twice daily, or 60 milligram once daily. If you here to give twice or once, if you want to give twice, we'll add it 20. We'll go give to once, we'll add it 10. So 50 will be here, 40 here will be 60, and 60 here, if once per day will be 90. So if most of the question came asking about the dose of enoxaparin in the weight between 50 to 69, and we'll give 60 milligram twice and 90 milligram once daily. We'll add it 30. Here we'll add it 30, we'll add it 30, we'll add it 30, here we'll add it 20, 20, 20, because difficult to memorize this. And here in the deltaparin, if the 50, less than 50, here the first two doses, here we'll add it 1,000, and the next two will add it 2,000. Here we'll also will add it 20, here 20 plus 20, 14 zaparin. and 5,000, 6,000, 8,000, 10,000. And here Vte once will double. Here will be this if this is about the deltabarin. So the initial dose of tinzabarin based on the weight is about 1.5 units per kilogram once daily. So this is about the therapeutic dose of tinzabarin and deltabarin and ixabarin. So we'll sorry. Here about the pre-mortem cesarean section will be performed by 5 minutes if the resuscitation is unsuccessful and the pregnancy is more than 20 weeks of gestation. Intravenous unfractionated heparin is preferred initial treatment in massive BE. So this is mentioned before. And the on-call medical team should be contact immediately urgent portable echocardiogram or CTBA within 1 hour of presentation should be arranged. If massive is confirmed, there is extreme circumference prior to confirmation. Immediate thrombophlexis should be considered. This is about additional service. In the initial management of DVT, the leg should be elevated and graduated elastic compression stocking applied to the reduced edema. Mobilization should be encouraged. Consideration should be given to the use of the temporary inferior vena cava filters in the pre-partum period for the patient with the iliac vein VTE with proven DVT and who have recurrent BE despite adequate anticoagulant. Main complication of inferior vena cava filters are migration and increased risk of the lower limb DVT and caval thrombosis and rarely infection. This is about the risk of the inferior vena cava filters. It can lead to migration and the increase of emboli and the increased risk of lower limb DVT and caval thrombosis and maybe rarely lead to infection. This is about maintenance treatment of VTE. The treatment of therapeutic dose of subcutaneous low molecular heparin should be applied during the reminders of the pregnancy and for at least 6 weeks postnatally and until at least 3 months of treatment has been given in total. Outpatient follow-up should be includes the clinical assessment and advices monitoring of the blood platelet and peak and level in appropriate 0.5 to 1.2 unit per ml for 3 hours post injection. Pregnant women who have developed HIT or have heparin allergy and require continued anticoagulant therapy should be managed with alternative anticoagulant. Heparin-induced thrombocytopenia because of this adverse effect on the fetus. Vitamin K antagonists such as warfarin should not be used for antenatal VTE treatment. What about the anticoagulant therapy during labor and delivery? This is very important here in this guideline. I hope not be difficult for you because I will try to make it simplified. Okay, when VTE occur at term, consideration should be given to the use of IV unfractionated heparin. So women on low molecular heparin for maintenance therapy should be advised not to inject any further heparin once it is established level. Low molecular heparin should be discontinued 24 hours prior to planned delivery. And subcutaneous unfractionated heparin should be discontinued 12 hours before planned delivery. So this is maybe confused with therapeutic dose and prophylactic dose of low molecular heparin from the delivery. Here, from the regional anesthesia, before mentioned before, will stop the regional anesthesia before 24 hours of the therapeutic dose and 12 hours of the prophylactic dose. Here in this guideline regarding the low molecular heparin and the planned delivery, is this spontaneous or is it intravenous? So if the subcutaneous unfractionated heparin should be discontinued for 12 hours before planned delivery. And if intravenous unfractionated heparin should be discontinued 6 hours before the planned delivery. So this is different between subcutaneous and intravenous. 12 hours for subcutaneous and 6 hours for intravenous.
This, Dr. Fatih, يعني no difference between therapeutic or prophylactic?
No, this is in the previous guideline, just to remember it. Okay. But here about, yes, no different. Low molecular heparin here regarding the planned delivery. Is it continuous, intravenous or subcutaneous? If subcutaneous, will discontinue 24 to 12 hours before the planned delivery and 6 hours before planned delivery for the intravenous unfractionated. What about the regional anesthetic should be?
Sorry, Dr. Fatih, can you repeat the previous point?
Okay.
The previous slide.
Here, this is about low molecular heparin regarding the delivery. So, low molecular heparin should be discontinued 24 hours prior to planned delivery. This is for low molecular heparin. If this unfractionated heparin, it is subcutaneous or intravenous. If subcutaneous unfractionated heparin should be stopped or discontinued 12 hours before the planned delivery. If you plan for induction or plan for cesarean section, you should stop the subcutaneous unfractionated heparin before 12 hours. Intravenous unfractionated heparin, just you need 6 hours before the planned delivery. But the low molecular heparin discontinue before 24 hours for the planned delivery. Okay.
Okay, thank you.
Sorry, Dr. Fatih. Sorry, Dr. Fatih. What about the dose, the low molecular weight heparin? We should stop it to 24 hours before the planned delivery in its therapeutic and prophylactic dose, or you mean only in its therapeutic dose?
Yeah, but for 24 hours, this is mainly therapeutic dose because here we discuss about the acute management. Here, no role for prophylaxis, thrombophlexis. Here, any low molecular heparin, this is we discuss about the therapeutic dose. This is the acute management.
Okay, thank you.
Okay, welcome. So we'll stop 24 hours. This is about regional analgesia. So it should be at least 24 hours after the last dose of therapeutic low molecular heparin. And low molecular heparin should not be given for 4 hours after spinal or after epidural catheter, mentioned before. And this should not be removed within 12 hours of the most recent injection. You remember this point? And thrombophletic dose should be given 4 hourly post-operatively, and the treatment dose recommenced 8 to 12 hours later. So here we have the algorithm we'll discuss. This is about the low molecular heparin regional analgesia and catheter remove. Here is the same like the previous one. And this here is the new one. So if low molecular weight heparin, regional analgesia, and spinal removal, spinal epidural catheter removal here, if there's prophylactic, if there's prophylactic low molecular weight heparin, you should wait about the 12 hours for the regional anesthesia. And if therapeutic dose, you will wait 24 hours for the regional anesthesia, okay? And after regional anesthesia, you should wait 4 hours to give the patient prophylactic low molecular weight heparin. And in case of prophylactic heparin, you should wait here 4 hours, 12 hours, and for removal of the catheter. And after 4 hours, you can give her prophylactic low molecular weight heparin. This is the recall question. Here, is it clear? So prophylactic low molecular weight heparin after 4 hours from the regional analgesia and from the removal of the catheter. And prophylactic low molecular weight heparin, you should wait 12 hours in both, in case of removal or the regional. Here, therapeutic low molecular weight heparin, you should wait 24 hours for the regional anesthesia. Here, any woman who is considered to be high risk of hemorrhage should be managed with IV and fractionated heparin until the risk factor for hemorrhage have resolved. What about the anticoagulant, postnatal anticoagulant? So, women should be offered a choice of low molecular heparin or the oral anticoagulant for postnatal therapy after discussion about the need for regular blood test for monitoring of warfarin, particularly during the first 10 days of treatment. Postpartum warfarin should be avoided until at least the 5th day, and for longer in women with increased risk of postpartum hemorrhage. Neither heparin or warfarin as contraindication in breastfeeding, and prolonged use of low molecular weight heparin more than 12 weeks is associated with significantly lower chance of developing post-thrombotic syndrome. This is about the postnatal. And persistent leg swelling, pain, feeling of heaviness, dependent cyanosis, chronic pigmentation, eczema, varicose vein, venous ulceration, and postnatal review for the patient who develop VTE during pregnancy or the perineum should be obstetric medicine clinic or joint obstetric hematology clinic. And thrombophilia testing should be performed once anticoagulant therapy has been discontinued, only if the result will influence the future management. This is about postnatal thrombosis. So, is it clear? So, we'll start the question.
I can share, Dr. Fatih.
Yes, you are welcome. Sure, Dr. Sir.
Okay, for each case described below, choose the single most likely management plan for the above. Okay, question number one, 39 years old woman who is 8 weeks postpartum started complaining of severe chest pain radiating to her left arm and then collapse at home. Her husband called ambulance and brought her to the accident emergency. Okay, type she is 39, 8 weeks, chest pain radiated to the left arm. This most likely myocardial infarction, collapse.
Yeah. So,
this myocardial infarction.
Yes, excellent. Yeah,
A.
because this is,
Myocardial infarction.
yes,
A.
answer is myocardial infarction. Agree?
This is myocardial
Yes,
infarction.
we agree.
Okay.
MI, yeah.
Yeah, the same I, because this is typical presentation.
Elder role. Yeah, and
The
she's
next
elder
question.
also.
That's right.
Yes. next question. Please, next question. Dr. Asir.
Okay, question 2. 42 years old woman with problematic vagina. Sorry, I will continue.
Yes, Dr. Asir. Yes.
Question 2. 42 years old woman with body-mass index 39 in her fourth pregnancy presented to HCP with chest tightness and the shortness of breathing. This is maybe pulmonary embolism.
Yeah, because this.
Sir, this is PE, pulmonary embolism.
Yes, this is B.
Body-mass
Actually,
index.
Yes,
yeah,
pulmonary embolism.
chest tightness, heaviness, tightness, breathlessness. This is the
Exactly.
keyword for the
Lack
PE.
of breath.
Yes, the third one.
PE.
35 years old woman was in a labor in her first pregnancy, and she had made slow progress and had been on the syntesinone for the last 12 hours. She was having emergency cesarean for the failure to progress when she suddenly collapsed on the table.
Yes.
Okay. This
I think amniotic fluid embolism.
Sir, amniotic fluid embolism.
Yes.
Yes,
Amniotic fluid
yes.
embolism. Yes.
Amniotic fluid embolism. It is during the cesarean section going on when she suddenly collapses. So it must be amniotic fluid embolism, sir.
Yes, that is right, Dr. Sadfa Ahmed. Yes, you're right. This is amniotic fluid embolism. Thank you, Dr. Suhair. Thank you, Dr.
So I am ready for the next 3 questions, Doctor.
You are
Dr.
welcome.
Fat.
You are welcome.
Okay. Yeah.
Okay.
Here's the answer. Yes. Answer 1 is the myocardial infarction. 2 is pulmonary embolism, and 3D is amniotic fluid embolism. Thank you. Thank you.
Embolism. Yeah. Okay. The next 3 questions. Okay. Yeah.
Sorry, Dr. Fadeh.
Welcome, Dr. Sayed.
Sorry.
Okay, thank you, Dr. Sayed.
So the next, shall I read it, or the lady having question, the colleague?
Okay. Question 4 and 5. Thank you,
Question
Dr.
number 4.
Thank you so much.
Shall I read?
Yes, Dr.
Welcome. Question number 4. A 25-year-old woman with a prosthetic hardware for mitral stenosis, she's on heparin, presented at 35 weeks of gestation in the labor. The heparin levels were mentioned with factor 10A levels antenatally. Shortly after delivery, she collapsed and resuscitation was unsuccessful.
Yes.
So she's been, she had a prosthetic hardware that was her risk factor, and she couldn't, and
can you please show the options again?
She got Yes, can we see, Doctor, the option, please? The risk factor,
again,
thank you, Doctor. You mark it very well. Yes, prosthetic hardware, and then she suddenly collapsed after the collapse, and resuscitation was unsuccess, and she was monitored with factor 10A level. Can I see the options, Doctor, please? Yeah.
Okay.
Yeah, she had the typical risk factor for the pulmonary embolism, prosthetic hardware, and also the suddenly collapse after the delivery. It sounds more like PA, pulmonary embolism.
This CPA?
Option. Yes, this is the
Unstable
option.
patient.
Yes. Question 4.
Pulmonary
The
embolism.
pulmonary embolism, and since she's unstable, we'll go for a CTPA.
Yes, this is the pulmonary
So
embolism. Yes.
pulmonary embolism is the diagnosis. Yeah, is the diagnosis. Yeah. Okay, question number 5. A 20-year-old primipara presented with severe pruritus, and she developed a petechial hemorrhage. 1 week after her admission for obstetrical cholestasis and severe liver enzyme derangement, following an induced vaginal delivery, she developed a massive postpartum hemorrhage from which she died.
So coagulation failure.
Yeah, she
Coagulation
had a
failure.
yeah,
the complication.
exactly, could be because of that, because she had a severe enzyme derangement. Yeah, can we see, Doctor, the yes, yes, and but can I see the list? Yeah, DIC, exactly, coagulopathy. Yeah, because of the hepatic derangement. Yeah.
Right. Yes,
DIC.
Agree
It's
with
a
B.
coagulation failure.
DIC, in fact, that's
B.
right.
Yes.
Option, I would say B, coagulation failure. Yes.
Yes.
Secondary to the liver involvement. Yeah. Derangement.
Thank you, Dr. Asio. Thank you.
You're most welcome. Shall I continue, or the other ladies, doctors? I don't know. I am ready, but whatever.
As you like, no problem. I have a lot of questions here. Okay.
I am ready. I will continue whenever the. I will continue whenever anyone. At least 2 more questions. Yeah. Okay. Question number 6. A healthy 32-year-old woman. She presents at 34 weeks of pregnancy age with sudden onset shortness of breath, breathless and pleuritic chest pain. She had a pulse rate of tachycardia 110 per minute, blood pressure okay 110/80, SO2 saturation 95% on air, and she was administered a therapeutic dose of low molecular weight heparin, chest X-ray, and lower limb Doppler or normal. Following consultation, the woman prefers the investigation that exposes her fetus to the lowest level of radiation. So which will be the lowest level of radiation? We said that is more safe. The for the mother, yeah, will be CTPA. CTPA. Because ventilation perfusion. CTPA, exactly. CTPA.
Chest X-ray normal,
because
so
VQ will be
VQ scan because chest X-ray normal.
Which one is her fetus to the lowest
It
level
is,
of radiation?
but because she wants the lowest level of exposure, CTPA, exactly. Because the mother wants the minimal dose. Yes,
yeah, this is a tricky question because just X-ray is normal.
That's right.
So go for VQ.
X-ray is normal. VQ.
You need lower level of radiation. So this is very important here.
That's right. That is it. Yeah, if we miss this point, yeah, we should point. Yeah, that is a very important key point.
Yes, we just X-ray normal, and then we said lowest level of radiation. So will be
CTPA.
Okay.
Okay.
Answer is E. Yeah. Answer is CTPA. Okay. Answer is B. E.
CTPA. Yeah. Option E.
Yes. All right. Okay. Who will share? Thank you, Dr. Asima. Thank you so much.
My pleasure. Thank you to you, doctor. You've been speaking non-stop. God bless you. Nearly 2.5 hours. God bless you, doctor.
I will wait.
You are welcome, Dr. Marfin. You are welcome.
A 23-year-old attends the antenatal clinic at 8-week gestation. She has DVT at the age of 18 years and found to have antithrombin 3 deficiency. So here we will give high dose of prophylactic. High dose, the option D.
Antithrombin 3 deficiency.
Yeah.
Previous history, okay?
And she has previous DVT also, doctor. So
Yes,
high risk patient she is.
Yes,
More than
right.
4.
Yes, and this is the right answer is
D.
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 We
D.
give her high
D.
dose.
D. High dose prophylactic heparin, and then 6 weeks postpartum. D.
You're
D
right.
is the answer.
D.
Yes, exactly D. Because this is the high risk, more than 4 antenatal. So we give her prophylactic high dose. Okay? An answer, yes, answer is D.
Prophylactic high dose, yes. Yes, prophylactic high.
Because
Answer is D. Okay.
Previous VTE and antithrombin 3 deficiency. Okay, agree?
Yes, that's all. She has a history. Yes, we
Yes.
agree. Yes, and
Yes, agree.
yeah, she's very high risk. Yeah.
Yes, high risk. Okay, thank you.
Yes, doctor.
Yes. Yes. Okay. Question 8, 9, 10.
Where is 9, 10? At 20. Shall I read? At 20.
Yes.
A 28-year preemie present to A&D at 16 weeks gestation with chest pain and breathlessness. She smoked 15 cigarettes a day and has not been seen her midwife or GP yet for her pregnancy booking. On examination, she was found to be very pale, dyspneic, and her pulse rate was 112 with respiratory rate 30. She is clinically stable and is admitted in high dependency unit. What we have to do? It is diagnosis or what? Can I see the options, doctor?
Please, options.
Chest pain or breathlessness.
Is it asking about the diagnosis
We need to give her
or for
molecular
treatment?
heparin. For treatment, yes. We should commence.
Yeah, but it takes a bit. Dr. Fatih,
For
please,
treatment.
before prescribing a low molecular weight heparin, I must do investigation baseline, full blood count,
Yeah,
coagulation profile, all basic needs.
The patient already in high dependence unit.
ECG and X-ray.
But before I will start any heparin, I will do the basic test to be my basic.
And admitted to the high dependence unit. So
now we will treat the patient.
So it.
I think it's better to
So it's supposed that the initial investigation has been done, chest X-ray and. So she will be on the therapeutic dose, doctor?
Yeah, we give her the low molecular heparin. I think his answer here is the C here. Commence low molecular heparin, lixobarine, 0.1.
C is the answer.
Commence low molecular weight heparin.
Yes.
Commence low molecular weight heparin and enoxaparin. Commence low molecular weight heparin.
But
Okay.
Okay. All the option is there. How I will start by this one? How I will know this or this? Because usually I will start the initial and the basic test first.
See.
How I know in the exam this or this?
What? See the
Because
option.
patient not came in ER. Patient admitted.
Patient now in ICU already.
Yes.
All this will be. I
This is the
think,
point.
I've done. Yes, I think it's high dependence units. This is the keyword.
Yeah, but if emergency, I will start by the basic test,
Yes, if
right?
the emergency and the patient.
So I think it depends. Yes.
Yeah,
Depends on the
independence of
scenario,
the patient.
Okay.
Okay, clear.
A 33-year-old second gravida attends a day assessment unit with dull ache in her calf muscle at 22 weeks as gestation. She has no other symptoms. On examination, it is found that she has tenderness in her calf. Duplex studies show deep vein thrombosis. We will start with the therapeutic low
dose of heparin.
molecular
Therapeutic
weight
dose.
heparin.
Is the same. I think the same answer for it.
Yes, the same item. That's it. Yes.
Confirm the diagnosis, I will start.
Yes, he is already confirmed. Show with
Vte, yeah.
Yes. This is
Okay.
C.
A 10
Comments
or
of the
24.
low molecular weight.
Yes.
10 or 24-year-old woman attend the antenatal clinic at 8 weeks gestation for further care. She is known case to have protein S deficiency and is currently on warfarin. Can I say? We have to stop the warfarin and start low.
Change to low molecular weight
Already
heparin.
I cannot remember warfarin.
Prophylactic dose of low molecular weight heparin.
Patient on
Change.
You should change to
You
low
will
molecular.
change.
We have to change it to low molecular weight heparin.
The option here is, I think, is B.
Option N, prophylactic low molecular weight heparin.
Option B, change to low
Option B,
doctor.
option B. Commence
B.
low molecular
B is
weight
better.
heparin and stop warfarin.
What about the change to? Agree with this? You should
B,
change
yes.
warfarin to the low molecular heparin regarding the
Yeah,
dose.
you will change.
Yeah, change
Exactly.
to low molecular
I agree
heparin.
with option B. Yes,
Yes,
option
agree
B,
with
it sounds better. Yes, doctor. B.
Better B.
And I have question. When I will start warfarin again?
After 5 to 7 days postpartum.
5 to 7 days.
After 5 days after delivery. 5 to 7 days.
Okay, thank you.
5 to 7 days after delivery, bridging technique.
Yes,
Okay.
Dr.
Thank you.
Yes,
I want to ask one
bridging.
question. I want to ask one question. Only if there is antiphospholipid syndrome, okay, antiphospholipid antibodies, then what will be the score for that patient? Not included VTD. Antiphospholipid antibody, only antiphospholipid antibody. It is high risk, low risk.
If there's previous VTE and there is associated with the antiphospholipid syndrome, this is the high risk.
High risk.
Because
If without VTE.
If without, we can give only score 1.
Only
yes,
one
score 1. If without any history, score 1.
Yes.
Score 1.
Yeah, it will be a score 1 only. Yes.
Okay, thank you.
Thank you, anyone who will share.
I will be.
Continue.
Hello. Okay, a 28-year-old woman is being induced for gestational diabetes at 37 completed weeks of gestation. She weighs 78 kg and her blood sugar levels are well controlled with insulin. She undergoes emergency cesarean section for fetal distress. The agent of choice for thromboprophylaxis is low molecular weight heparin for 10 days.
Yeah.
10 days.
Low molecular weight heparin for 10 days postpartum. 10
days. Postpartum 10 days.
Emergency section, yeah, for 10 days.
Option.
Sorry. This is a question? No, sorry. Oh, this is the option, yeah.
Low molecular weight heparin, doctor, for 10 days.
What is the option? Your option? شوفها لو بالكويتمرين
1.5.
prophylactic
Prophylactic low molecular weight heparin enoxaparin 40 milligram once daily. And option N.
N.
because
Yes,
her
you're right.
70
Yes,
is
exactly.
N.
Yes. Just to give her enoxaparin 40 milligram.
N.
Daily.
Option N.
Yes,
Prophylactic
agree with that?
enoxaparin.
yes, agree for 10 days.
Yes.
Weight
Prophylactic
78
low molecular
kg.
weight heparin 40 milligram.
The most appropriate N.
Yes, thank you. Yes, you're right. Question 12.
Well, a 37-year-old postpartum mother present with calf pain. She is diagnosed with recurrent DVT and received therapeutic dose of low molecular weight heparin. She is otherwise well not stable. Further evaluation shows her right common iliac vein thrombosis. Here thrombolysis we will do.
Yeah.
Or vena cava or a filter. What is the
She's
option?
otherwise there.
Yeah, need filter, need high dose.
Yeah, are you? Yes.
You can go with filter.
Cava filters, doctor.
Option, please.
All right, exactly. Agree with A. Cava filters.
Cava filter?
A. Cava
Yes,
filter.
yes, agree with A. Yes, all right.
Yes, yes.
The Cava filters, A. She's already been given a therapeutic dose of heparin, so additional thing is Cava filters.
Yes, you're right, exactly. Okay, thank you. The question 13.
Okay.
We'll share.
I am ready. Do you want if someone?
Yeah, welcome.
If someone else? Yeah, I will read. Yeah, okay. Okay. Next. Question. Where is the question? Question 13. Okay, question 13. A 36-year-old lady para 3 with a BMI of 32. She's carrying a twin pregnancy at 11 weeks of pregnancy and attends the antenatal clinic for the advice. She smokes 2 to 5 cigarettes a day. Her previous pregnancies were uneventful and resulted in a healthy newborn infant at term. So how many scores she has? Her age is 1, her pregnancy 2, her BMI is above 3 factor.
Para 3.
Smoker.
No,
4.
para 3 itself is not. If it was para 4 or above, para 3 is just the third pregnancy. It still is
score of 5. Score of 5.
Score of 5.
So far she has it. Twin
Low molecular weight heparin from now till 6 weeks.
From now
from
6
now
weeks.
She needs, but by considering this factor, she has 3 risk factors. So from 28 weeks, 28 weeks and until 6 weeks postpartum, doctor. 28 weeks and 6 weeks postpartum.
She has 5 risk factors. First is her age, 36, BMI is 32, para 3,
trimester to 6 weeks
IVF,
postpartum.
and one more IVF or a smoker. 5.
And also twin pregnancy.
The age.
Yes,
twin
pregnancy, that's
multiple
true.
pregnancy,
No, actually, yes,
smoker,
that is absolutely right.
body mass index.
I forgot about the smoking and the IVF. That's true. Yes. She needs from the first trimester and 6 weeks postpartum. Yes. That's right.
Very high.
Right. Yeah.
Very high. Yes, we'll start the first
yes,
trimester.
she's a Exactly. I didn't. I forgot to consider the smoking and the yes, conceiving. Yeah, that's
There's
true.
so many
Okay.
risk factors all together. So, you know, until
And
6
IVF,
weeks
yes.
postpartum is appropriate. In fact, the most suitable.
She had all the risk.
Yes. Question number 14. A 31-year-old nulliparous woman with a BMI of 29 at 26 of pregnancy, she asked for advice about any thromboprophylaxis because she will be flying to Dubai, which is 7 hours flight. So
TED
only her
stockings.
duration of flight, which is above 4 hours,
TED
is a risk factor.
stockings.
She needs that. Yes.
Only
She
stockings
needs
avoid the
that
dehydration.
Low
from
risk, only TED stockings would suffice.
Avoid the dehydration.
yeah, she has only the 4
Anti-hemolytic
hours.
stockings
So
would
only
be.
that for the
She's
hydration.
very
She's
low
low risk.
risk.
Only hydration
Nothing
and
significant in the history.
exactly.
Yeah.
So what is the answer? What is
A.
the correct answer?
A
Answer is A.
Embolic. Okay.
It's more than 4 hours. So, okay, I agree with Antium.
Yeah, because she's low risk
Yes,
patient.
because the flight is above 4 hours. Exactly. Yes,
more
yes,
above that.
that's right. Yeah, this is the only risk factor of she needs that the compressive. Okay, anti-embolic. Yeah. Okay.
The last 3 questions.
So the pressure of this anti-embolic pressure is should be, doctor, or you mentioned in the lecture 15 to 30 millimeter mercury
12 to 14.
of compressive
12 to
pressure.
14.
How much?
12 to 14.
Okay, okay, okay. Yes. Okay, thank you. So the next question. A 26-year-old Gravida 1, she attended the antenatal clinic at 14 weeks of pregnancy and her BMI is 29, and she gives a history of previous VTE during her post-operative recovery, a hernia operation. Okay, so her risk factor is a unprovoked previous of DVT1, and what else she has, the other risk factors? Yes, from 28 weeks until 6 weeks postpartum. Yes, because it's
We can
unprovoked.
start with 28
Unprovoked
weeks and
It is a
10 days
provoked
postpartum.
VT. We can start low molecular weight heparin from 28 weeks till 6
And
weeks
then
after
10 days
delivery.
postpartum.
That's right, because it's unprovoked. If it was provoked, it was high risk. If it was without any reason, yeah, if it was a VT, yeah. Okay. So the option will be
option D. Sir, option D.
exactly option D. I agree.
D
But
or
no, you know, it said D is not good because it said 10 days.
6 week
Option
postpartum.
E, doctor.
Option E.
E or E?
6 weeks. 6 weeks.
What about the E, Dr. Ema?
E.
It is
E as elephant. E as elephant.
Yes,
E,
you are right.
okay, okay.
Yeah.
You commence
Yes, E
at
as
28
elephant.
weeks
Yeah.
and
Yes.
continue for 6
Exactly.
weeks.
For 6 weeks.
Yeah.
Because D
Yeah.
for only
You
for
know,
10 days.
in the real exam, if we be in rush and we don't read that properly, we go easily mistake for 10 days. If we only see the 28 weeks and quickly we choose that answer, we lose.
Just
We
look
lose the
for
mark. Yeah.
at 28 weeks and choose D. So here you should complete that.
Exactly. That is mistake.
Because any antenatal, you will give 6 weeks.
Yeah.
Yes.
To read properly, right? Yeah. Yeah, exactly. Always, if we give until it should be continuous 6 weeks postpartum.
Yes.
Question 16.
Question number
16.
16. A 23-year-old woman with a previous history of unprovoked VTE. She attends antenatal clinic at 10 weeks of pregnancy age, and she is known to have antithrombin deficiency. Oh, she's very high risk.
Starting from the first trimester. And then
Exactly.
continuing
Antenatal and
6
6
weeks postpartum.
We can
Starting
start the
immediately and
molecular weight
6
heparin
weeks.
throughout the
6
pregnancy
weeks
until
postpartum.
6
yes.
weeks
And high
postpartum.
Yes.
Yes.
dose.
Why
She will
high
take
dose?
standard dose.
Low molecular weight in the first
Because
trimester and 6 week
Answer,
postpartum.
answer is C. Answer is C.
Standard
Starting
dose
from the
It
70.
is
first
C.
trimester and
C.
continue for 6 weeks
The answer
postpartum.
is C.
yeah,
Standard
high
dose
dose,
from
high dose.
first week and
High
continue
dose.
it to 6
Wow.
weeks postpartum.
On no molecular.
Antithrombin deficiency and previous VTE.
Yes, because this is the
She's very high risk.
more
That's
than
why
4
option
high.
H is better. Yes,
Give her high dose
higher
of
dose.
levodopa.
High dose,
Okay.
exactly.
Yeah, high dose.
It's 50
Three
or
patients we had to
55%
give.
of treatment dose from the first trimester.
Yes, yes.
Agree
Yes,
with that?
doctor. From the first
Okay,
trimester, we
okay.
agree. She's very high
Yes,
risk.
yes.
Yes,
Yes, this is high
yes,
risk
and
patient.
continue until
More
yes,
than 4.
very
Yeah,
high
more
risk.
than
Yeah,
4.
yeah. She has a DVT and yeah. Okay.
So the last question.
I will do.
Yeah. We. Oh, do you want I continue or it is the last question? I will continue. I think because it's the
I will
last one. It's okay.
No, doctor. I want a pregnant lady complaining of severe chest pain. X-ray was normal, but next is investigation. This is CTPA. CTPA.
This
VQ.
VQ.
X-ray was normal.
Pregnant lady comes
VQ
severe
scan.
chest
VQ
pain.
scan.
The D. VQ scan.
VQ scan. VQ
CT
scan.
scan. VQ, ventilation perfusion, VQ scan.
Normal,
Yes,
yes,
VQ.
normal.
VQ scan.
VQ scan, yeah.
Because it's normal.
D.
Yes.
Option D.
Normal.
Okay.
Option D.
Option D.
Yeah.
Option
D.
D.
The D.
Yes, the D. Okay. Thank you all. Thank you so much.
Thank you, Dr.
Say
Fateh.
thank you very much.
Thank you.
Jazakallah. Thank you so much. Allah
Thank you, Dr.
Hafiz.
You
Fateh.
make our life easy.
Thank you, doctor.
Thank
Thank
you,
you.
Dr. Fateh, very much.
Very interesting and easy
Appreciate
become very easy.
Thank you.
Mashallah.
Thank
Thank
you.
you, sir.
Thank you. Welcome.
Doctor, please
Thank
upload
you.
lecture soon so that what part we miss we can read. Please.
Great,
Thank you.
great. Wallahi. Thank you, Dr. Fateh. Thank you. Appreciate.
Thank you very much. Jazakallah khair. Jazakallah khair.
When you will take governance lecture, doctor?
شكرا
Yeah.